FADIC offers a variety of international online trainings accredited by FADIC and provided by well-reputed professionals in the field, which means that you can always keep up with the latest topics in your specialty wherever you are and whenever you need it.
Assalamu alaikum جميعا. I'm Ashwag Ali. I'm a clinical pharmacist from Saudi Arabia, and today I'm going to present a case presentation of community-acquired urinary tract infection. For my case, she's a 53 years old female presenting to outpatient clinic, and she was complained of pain when only passing a small amount of urine, and it worsening at the end of voiding urine. She also complained about frequency of urine occurs throughout the day and night, and also urgency without vaginal discharge. Actually, her symptoms start 2 days ago suddenly, and she had no previous history of UTI over the past 4 years. And also she reveals there is no hematuria or fever during the examination. Her past medical history include knee osteoarthritis, and this condition started with her 3 years ago. And hair medication, actually, the past hair medication include paracetamol for pain, meloxicam and ranitidine for osteoarthritis, but the ranitidine was only for gastroprotection. And currently, she's only on paracetamol, PRN, for management of the pain. Her social history, she's only married. And the review of system revealed that she has a positive knee pain, worsen with activity, and actually she managed that with paracetamol PRN. The genitourinary revealed that she has a positive burning when urination and positive urgency and positive frequency. Actually, there is negative blood in the urine and no vaginal discharge. Her physical examination was mostly normal, and there is no lab result at the clinic when she came. So for the clinical assessment, my clinical assessment, the patient was presented with the sign and symptoms of UTI, which is classically dysuria, frequency, and urgency. And usually in human, absence of vaginal symptoms in settings of UTI infection symptoms increase the likelihood that she might have a urinary tract infection is present. So cystitis is usually manifested as dysuria with or without frequency, urgency, or suprapubic pain or hematuria. Actually, because she doesn't have a fever and chills or flank pain, nausea, and vomiting, that might indicate she might not have pyelonephritis. So here we can see the clinical assessment algorithm for patients present to the outpatient with clinical symptoms of UTI at the outpatient clinic. So if we follow that, we end up that she might have acute uncomplicated cystitis, and it's uncomplicated because actually she didn't had any risk factor that might makes us the therapy would fail, such as she's not diabetic, she's not pregnant, she doesn't have any hospital-acquired infection, and there is no kidney injury. Actually, the pathophysiology for her condition usually caused by pathogens such as E. coli, which represent high percentage for community-acquired uncomplicated UTI. Also, there is other organisms such as Klebsiella pneumonia or different species, but until now we don't know the causative pathogen. So the pathogenesis actually, the pathogenesis of UTI in women begins with contamination of the preurethral area with uropathogen, followed by colonization of urethra and migration to the bladder. And at that point, it might cause inflammation of the bladder, or what is known as cystitis. Then, if the pathogen ascends to the kidney, it might cause inflammation of the kidney at that point. So for goal of therapy for such cases, we should effectively eradicate the infection and to prevent the associated complication with minimize the adverse drug event and costs associated with drug therapy. So we should consider factors such as likely pathogen, and resistant rate at that geographic area. Also, the desired duration of the therapy. Most of the patients compliant with short duration. Also, we should see the clinical efficacy and toxicity of various agents available at that case, and also the cost and availability of the agent. Here we can see a table, very nice table, that shows the overview treatment of UTI infection. And it shows us the uncomplicated UTI and the most causative pathogen and the most drug of choice to treat that causative pathogen. So, for example, if we have Klebsiella pneumonia, the most, for example, causative, the most effective choice would be bacterium. And there is another table that shows the recommendation of Infectious Disease Society of American Guideline. So the Infectious Disease Society of American Guidelines suggests the first-line agent could be nitrofurantoin, bacterium, or phosphomycin, or phosphomycin or I can't see the slide, sorry. So this is the first 4 agents, which is recommended by the American Society of Infectious Disease. And also the second line agents would be the Cipro or Levo or beta-lactam, such as augmentin. Also, the recommendations suggest short duration, short course regimen, single dose to 5 days as a first-line therapy. And it shows that it's effective as long duration to achieve asymptomatic relief and with a fewer adverse drug events. So for my pharmacological therapy plan, if there is diagnostic uncertainty regarding the cystitis versus pyelonephritis, the usage of nitrofurantoin, phosphomycin, and pivmecillinum should be avoided because they do not achieve the adequate renal tissue level. However, penicillin and amoxicillin should not be used for empiric treatment because they have poor efficacy and high prevalence of resistance to those agents. And beta-lactam are the second-line agents because they are less effective than fluoroquinones and trimethoprim and sulfamethoxazole or bacterium. So on day 1, she starts empirically on bacterium double strength, 1 tablet orally twice daily for 3 days. And at that point of time, urine culture was ordered, and the patient was advised that she should take the medication on empty stomach with a full glass of water. For the non-pharmacological therapy, drinking cranberry juice is an alternative remedy to treat and to prevent UTI. Actually, there is a Cochrane review identified 10 studies comparing cranberry juice or tablet to the placebo. And they found that it reduced the UTI, especially for the woman who has the recurrent UTI infection. And the only limitation on that review that the drop rate was high, and maybe because the patient cannot tolerate this juice for long duration. And there is still, we still need clinical trials such as randomized controlled trial to improve its clinical effectiveness. So on day 3, when she came to the clinic again, the patient wasn't approved, and the urine culture revealed she has Klebsiella pneumonia. And if we see the urine culture in the next slide, the culture shows it is sensitive to most of the antibiotic except to ampicillin and nitrofurantoin. So we start to give her levofloxacillin, 500 milligram, 1 tablet once daily for 5 days. And we advise her to take the medication 2 hours. We advise her to take the medication 2 hours before or 4 hours after eating, and she should be not taking it with, for example, multivitamin or calcium, especially because she has a problem with her knees. So that leads us to the clinical outcome after finishing her course. Actually, she should be I mean, for example, she takes already Bactrim, which is the first-line regimen for first drug of choice in her case for 3 days, and it should be. The clinical studies reveals that the rate of infection is decreased. However, she didn't. I don't know what is the reason, but she didn't get well. So that's why by the end of levofloxacillin course, all the symptoms and signs was resolved, and there is no adverse event was reported during the treatment. Although there is, although the chloroquines have minimum side effects such as nausea and diarrhea and photosensitivity or headache. For the economic outcome, treatment with Bactrim is considered to be a cost-effective choice because it might, if we see here the estimation, it might cost from $6 to $8, maybe according 30 riyal, 30 Saudi riyal, and the patient. Here another estimation: if the regimen for 3 days with fluoxacillin, with levofloxacillin, it's around $25, which is 100 riyal. That's why we should, as we can see here, levofloxacillin is expensive drug of class, and it's broad spectrum, and therefore it should be resolved for community where the rate of resistance is high, especially for Bactrim, or if the patient cannot tolerate it for any reason, or if the patient has a recurrent UTI. So that leads us to the resistant outcome, which is very important when we're implementing antibiotic stewardship program. Short duration of therapy is the important factor that we should consider it. In fact, she is treated for a short period of time for Bactrim, but for some reason it doesn't improve. She doesn't improve. But after the levofloxacin, she's started to improve within the limit 5 days, which is the recommended duration of therapy by the Infectious Disease Society of American guideline. So I hope we will not reach one day that antibiotic is not working. And there is emerged a study that found that there is a high strain resistant for levofloxacillin, especially in the Middle East. But I tried to find some study to show the percentage, but in fact there is very, very few. But we should take our caution. So thank you for your listening, and I would like to take the opportunity to thank Dr. Rasha and Dr. Mohammed Hasib for this course. It was really useful for me because I never had a rotation in infectious disease, and that really helped me a lot.
FADIC, revive your clinical career.